Hi, everybody, and welcome to this edition of TCOYD Live Ask the Endos. I'm one of your endos, Jeremy Pettus, my good buddy.
Steve Edelman.
And this is a special Type 1 edition. As it turns out, Steve and I both have Type 1 diabetes. So we're excited to kind of get your guys' questions, answer them here live in real time. So whatever platform you're watching on, just write in your questions. And through the miracles of science, it'll be kind of funneled here to my computer. So I'll scroll through them. We're going to get through as many as we can. In the time we have, we're aiming for like 30, 45 minutes. We'll try to like cluster things and, if this is a technology question or whatever. So don't get, upset if we don't get specifically to your question, but we will. I think we always try to answer them online afterwards. So make sure to get you guys an answer. You want to say hi?
Yeah, say hi. Jeremy and I love doing this. We just like taking questions, any type of questions that relate to type 1, no preparation. And we do so much type 1 as part of our daily lives. We love these things off the cuff. We also we alternate with the type 2s. But I think the other big announcement is, don't forget, our upcoming One conference. I believe it's going to be August 14th through the 16th at the Paradise Point. And this is our one live event of the year solely for folks with type 1 diabetes. And if you've ever been there, I don't have to tell you how great it is. And for those of you who haven't been there, it's a special event.
Super fun. Like, really, I have no problem kind of pushing this event because it's so fun. I really enjoy it. A couple days in San Diego, we have lectures for people to learn from. We have time to hang out at the bar. Eric, you can't see behind the camera, usually does his Beatles band.
Yeah.
So it's just a good time, and it does sell out. So make sure to go online and register.
And a lot of our speakers are endos like us, so they get it.
Yeah.
And what do you mean you don't feel bad about pushing the event?
Well, I mean, like hardcore. Like, some of the stuff we do is not great, but this is amazing. I'm kidding. So yes, we're living, and breathing with type 1 diabetes. I just got a little low. I'm fine. So I got my big jug of peanut butter pretzels, which I love to eat, especially when I'm low.
He didn't eat too many.
This was full 5 minutes ago. All right. So without further ado, we're going to get into some of these questions. So, these are no particular order or anything of importance, anything like that. So one of these questions is about essentially sharing my experience or our thoughts on the Medtronic pump, but specifically that the Medtronic system now works with multiple different CGMs. And the one that I'm using, I use the Medtronic pump with it's an Abbott sensor. It really is the Libre, but they call it the Instinct because it's one that's specifically made for the Medtronic pump. So you can't just grab a Libre off the shelf and have it work with the pump, but it is, for all intents and purposes, a Libre sensor, which is great because for the longest time I was using like the Guardian sensor, which is it's antiquated and outdated. It has separate transmitter you had to charge. It's a little painful. It didn't last that long. It was accurate enough, but it was just kind of a pain in the butt to put it on. So I've really enjoyed. Now I've got this 2-week sensor, super accurate. I think the algorithm is great. So I kind of view this as, now that they have a modern CGM, it's kind of unchained the Medtronic to this antiquated system. So now it's in line when I talk to people about what pump they should be on. All of a sudden, Medtronic's back in the conversation with Tandem and Omnipod and Sequel and all these other things. So welcome back, Medtronic.
Yeah, they come a long way since the 670G and their very first sensor. We should mention, to be complete, some people are still using the Gen 4 and they want to stay with it. God bless you. And then there is the Simplera sensor, which has the same form factor as a transcutaneous sensor. It lasts 7 days. Is that right?
The which one?
The Simplera. I believe it's 7 days, and some folks are using that as well. And the reason why they have these sensors is that Medtronic MiniMed is a worldwide company. Certain companies have access to certain sensors and so forth. But I think the Instinct sensor is a huge step forward.
Yeah. All right. So what about the Dexcom 15-day sensors? Available yet? And have they fixed the production issues with the G7? So maybe some background there that people, maybe you haven't heard, but the G7 is kind of the first time that we've had a new iteration of the Dexcom that's had some issues. And a lot of people have no problem with the G7. They love it. It's smaller. It's a quicker warm-up, all those features that make it a positive. But a good number of patients have issues with it. And those can range from inaccuracy of, kind of like going all over the place, losing signal, connectivity is another one.
Failure on setup, on startup was a big one.
And so people have been, just holding on to their G6 for a long time. Some people, because they were worried about going to the G7, and now they announced that they're getting rid of the G6. So it's like, okay, we kind of, have to go to the G7. And so they have this 15-day sensor. What do you tell people, Steve, about if this is going to fix the issues or not?
Well, I looked into this in detail recently, and Jeremy and I did a podcast with the CEO, Jake Leach, and basically, make a long story short, they had an issue in the production line. And these production lines are huge. They make millions of sensors. They buy parts from many different companies, and they missed an error. And these sensors went out in the world. And now, according to the folks at Dexcom, the number of people asking for a replacement, which they will do without asking any questions, is coming down gradually because these sensors are getting taken out of use. Now, I use the G7 with my loop, and I think the 10-day, which has been cleaned up, and they are not going to release the 15-day until, of course, it's going to run perfectly. And they are asking for forgiveness, basically, and they have the 15-day has a grace period as well, another 12 days, and it does have some other features that we don't have to get into now, but they're nice features. Titration for folks on basal insulin, mostly type 2s. They're going to be able to hook up to apps that can take a picture of your food and tell you how many carbs are in the food, things like that. But I think the most important thing that you and I would agree on, 15 days plus another 12 of an accurate sensor is a big improvement over the 10-day.
Plus another 12?
12 hours.
Oh, got it.
Sorry.
Yeah, and I think the proof's in the pudding. We'll see when this gets out into the world and what people say. I think it's just that kind of word of mouth. Like, when the G7 first came out, seemed great, and then all of a sudden people started. I remember telling you I was having issues with it, and you told me to kind of get over with it. And then, more people kind of like started coming out about it. So hopefully this has fixed the issue. Look, we've been using Dexcom for a long time. We hope that this is improved. And this is kind of the way that things go, though. Thankfully, we have other options now. Maybe the G8 will be stellar and the Libre 4 will not be great. I mean, who knows?
G8.
Yeah, when we get there.
But I should just add that any sensor can have problems. And Abbott just had a recall. They had similar issue. It was something in the production line. They knew the serial numbers. They sent out to everybody to get them off the shelves. And so remember that anytime they're using any type of sensor, you should always theoretically have a finger stick device around and double check. Those aren't perfectly accurate in and of themselves, but they're not fraught with these type of issues.
And we've been talking about this a lot, that now there is a lot more flexibility than there used to be.
Yeah.
We're getting closer to you just pick your CGM and you pick your pump. We're not quite there yet. But Tandem Omnipod, you could be on the Dexcom, you could be on the Libre. So a lot of offices have samples now, so we actually have them. Usually an endocrinologist's office, not necessarily like primary care. So you could say, I'm on the G7, let me try the Libre, or vice versa. Or if you get a prescription for one of them, it's a lot easier to change kind of to the other one now. So people have this kind of old feeling like they're locked into their CGM. That's going away too.
Yeah.
So if you do have an issue with one, try the other one.
Yeah, we always talk about pumps, but we should mention you folks on multiple daily injections. Jeremy and I both have patients that do extremely well. They just don't feel like using a pump, and that's their prerogative. But there was an announcement with the smart pen, it's called the InPen, that it's hooked up to CGM in a much better interface and software that helps people with diabetes manage their diabetes almost as if they're on a hybrid closed loop, but not really, because the pen doesn't automatically give insulin. So there are technologies out there that will help MDI users, but once again, you might be someone that likes to use the disposable, fling it away, and you have your time in range is excellent.
Yeah, and if you're playing the TCOYD home drinking game, every time Steve hits the mic, you got to take a shot.
I didn't hit the mic.
So far he's been doing pretty good, but you've hit it, I'd say, twice. So we'll start the game.
Wait,
now
hold
and
on.
see
Eric, did I hit the mic twice?
At least once.
Okay. I've seen him twitch twice.
All right, let's change gears a little bit, and we'll probably come back to technology, so don't worry. This particular question says, I have 3 kids, 1, 3, and 7. Should I get their antibodies tested? So there's a lot to unpack there, and we'll make this global to everybody, whether you have kids that are 1, 3, and 7 or whatever. So the issue is, when do we screen people for type 1 diabetes? This is a big topic. So first of all, if you have type 1 diabetes and you have kids, they're at higher risk of getting type 1. It's about a 10-fold increased risk. That sounds awful, right? But you go from about a 0.5% chance of a child having type 1 diabetes without a parent with type 1 to about a 5% chance if you are a parent with type 1. So I hit the mic there. So I don't know if you have to drink for me. Yeah. So that's a 10-fold increased risk, right? But it still means there's a 95% chance that they won't get type 1 diabetes. A lot of parents I see think, sometimes actually I heard people say, I don't want to have kids because I don't want to give them type 1. And it's just like, it's not that case at all. So now we know you can get antibody testing, and there's no global recommendation for what age. You don't even have to do it if you don't want to do it. However, we do have a medication now, Tzield, that's approved to help delay the onset of type 1 in people that have these antibodies that are positive. Right now, I think it's for kids 8 years and older. They do have the pediatric studies. I don't know if it's gotten lower yet.
I can comment on that, but when you're finished.
So, you can ask your pediatrician to order the labs. You can actually go online. It's type1tested, I think, .com. They can actually send you a home kit where you can do like a finger prick on your kids. So, the ages, it really kind of depends. Sometimes they're saying like, let's do around 4 or 5 when they get into kind of like preschool. If you do it at least once, that's a great start. If you wanted to do it again, probably one time again before they reach adulthood. And, we can get into like what all the different results mean, but it's a very personal choice. If you want to know if your child's at risk for type 1 diabetes, sometimes parents will say, I recognize the symptoms if they're peeing more or whatever. I don't want to worry and get these antibodies tested. Other people say, I absolutely want to know. Maybe they'll be a candidate for drug therapy. So we're having this conversation a lot more.
Yeah, what I can add to that, Jeremy, well said, is that I was on a conference call this morning with a bunch of folks from Sanofi and other advocacy groups, and they gave an update on what's going on in the FDA with the Pettus study. So that was down to ages 2 and above. And the data was excellent. They published some of the preliminary results just a few days ago. It's safe, and the FDA gave them a fast track that once the study is completed, then they will put it through their regulatory process. And I think that's huge because we know that in the younger ages, 2, 3, 4, those antibodies can be really high. And I think you and I would agree that if you're going to go for this therapy, this preventative therapy that reduces the destruction of the beta cells, then why not do it early? Mm-hmm. And I learned that from you. The other thing that came out is that they're waiting from the FDA now for the indication for folks that are newly diagnosed type 1, stage 3.
And this is a big distinction. So it's always worth pausing there.
Yeah.
So right now it's approved for people at risk that have these antibodies that are positive to delay the onset of getting type 1. And now we're saying, okay, what if you're diagnosed with type 1? Can you give this drug to help preserve beta cell function, insulin production? And the answer in the clinical trials is yes. It's at the FDA now. It's been delayed like a little bit, so we'll see what happens. But it could be that we get that approved relatively soon. Because what happens when someone gets newly diagnosed with type 1? It's, what can I do? Can I preserve these cells? Is there anything? And up until now, it's been no.
Yeah.
Control your blood sugars, do your best, but sorry. And we might actually have something in that category too.
Yeah, we had a video on that. And Eric, was playing someone that got newly diagnosed. And Jeremy and I went nuts because I've learned from Jeremy and others that when you're newly diagnosed with type 1 diabetes, you still have about 20% of your beta cells left. That's on average. And the sooner you intervene and reduce the destruction of those working beta cells, the better off you'll be for a long time. And there's some long-term benefits. So Jeremy and I are big proponents of screening, and I do hope they get approval for new onset type 1. That'll be huge because it's really hard to screen people now. Most people don't even have a family history of type 1 when they're diagnosed, like Jeremy and I. So it's really hard to find these folks. But when you get type 1, you start looking for what to do. And I think that'll be huge.
Yeah. Well, we've done 3 questions, I think, like 15
Well, come
minutes.
on. Well,
so
you're
let's
talking
pick
a
it
lot.
up. No, you're talking a lot.
No,
So
you're
we're going to
talking
do rapid fire round.
Okay,
I always have to make
hold
you
on.
do that.
Let me get out my timer.
Yeah, no, it's right there.
No,
all
how
right,
long
so,
do you get?
Okay, so what's going on with islet cells as a cure? Well, company Vertex is still moving through clinical trials, islet cell infusions into the liver. Kind of big picture is they work. People need immunosuppression. So this isn't, something that's going to be for everybody when it comes out, but maybe people that have had long-standing type 1, real issues with hypoglycemia. So this looks like it's on the path towards approval in clinical trials now. So, you can look into like your local places to see if it's available, but not yet.
Yeah, and I'll just add that there have been many people have gone through this study and are free of using insulin. And so I think that really we're waiting for more data to come out on the full group of patients that joined the clinical trial.
All right, this is a nice short and sweet one. Which emergency glucagon would you recommend, the nasal or the pen? And the answer is whichever one you want to use, or importantly, whichever one whoever's going to be giving it to you would want to use. So there's no better one in terms of how fast it raises your blood sugars. Sometimes, though, you might have a spouse or something or other that says, I don't want to do an injection at all. That scares me, but I'm okay with the nasal one, or maybe vice versa. The pen now is preloaded. It's very easy to use. It's like an EpiPen. You can do it through your pants. Sometimes insurance will dictate which one you get. As long as you have one, you know where it is, your significant other knows where it is, or family friend member, then that's the answer.
Let's go to the next question.
Oh my gosh, nothing to add.
Well, because
that's
I want to show
amazing.
you. You know the talking.
Okay. All right, then I won't say anything.
No, I agree with you. That was a great answer.
Okay. You just had to add that you agree to me. Thank you. I heard you say something about a device for ketones. How can it help type 1, Steve?
Well, I'll make this brief. Abbott, the makers of the Libre, have been working very hard on coming out with a continuous ketone monitor. It's going to be in the same sensor as the glucose sensor. We don't know exactly what the form factor is going to look like, but it's going to have alerts and alarms and levels. And, we don't really know the natural ketone levels in people with diabetes who are healthy, like Jeremy and I, through fasting, through exercise. But one thing for sure, it'll help tell people that they're going into a serious condition called diabetic ketoacidosis early, where they can intervene, take insulin, fluids, carbohydrates, and prevent an emergency room visit and even a hospitalization. And I think even for the pediatric population, it'll be extremely important for parents of young kids that can't really verbalize how they're feeling. Can you add anything to that,
I would
please?
just say it's like an airbag on your car. Most people go the whole life without using it or, needing it. But, man, you're glad it's there when it's there. So, do I need to know what my ketones are right now? No. But I would need to know if they're going into a problem area. So that's just a nice feature, I think, to add onto these.
And these problem areas, just quickly, are your pump line pulls out and you don't realize it. Next thing you know, your blood sugar's 500. You've got nausea. You're feeling terrible. And so these systems would tell you long before you got to the point of feeling nausea and vomiting. So I think there's going to be a lot of uses for this. For people on SGLT2 inhibitors like Farxiga, Jardiance, they can get what we call euglycemic DKA. Won't go into it now, but it does help pick up DKA early. That can prevent, hospitalization, sickness, and long-term complications actually as well.
Got it. All right, so can I use Afrezza they have their specific pump, but can you use it with an AID system, Steve? What do you think?
Absolutely, yes. All I'll say is this, that in February, our newsletter has an article that you and I put together on answering this question. And the answer is yes. Every system's different. Every algorithm of these hybrid closed-loop systems are different. It's not officially approved, but we have found that when we use it ourselves in our two different systems and our patients, these algorithms seem to adjust. And people do well on it. And it's the best way to bring down those sticky high blood sugars when you can't do it with sub-Q insulin.
Yeah, I'd say this is where TCOYD really shines. Technically, by the book, you're not supposed to. But that just generally means they haven't done the clinical trials. They haven't evaluated that specific issue. So they just have to make a blanket statement like, don't do it. We found in the right situations, people being educated on how to use it, it works perfectly well. Another great example is like, sometimes they'll say you have to put your sensor on the back of your arm, for example.
Good example.
And we're like, no, you can put it anywhere that you have like a little bit of fat. I mean, Steve wears his Omnipod like up here for crying out loud. So, do it safely, do it, kind of educated. But we found that it works.
Yeah, listen, you're wearing a CGM. It has alerts and alarms. And you could look at it when you first try it and see how you respond in different situations. But I would say there's no better way to bring down a blood sugar quickly without the delayed tail of subcutaneous insulin that can cause delayed hypoglycemia.
All right.
We should work for mankind.
Yes, seriously.
We got a dime for every time we mention this drug. Mike, where are you?
So this is one for you, Steve. So have you tried the Twiist pump yet? If so, do you have any quick suggestions with getting the settings dialed in quickly? So I would say maybe tell people what this pump is. And then, yeah, Steve tried it for, I don't know, a little while and actually wore it when we did our most recent food challenge just went out, where Steve and I ate a California burrito and could see who tried to, stay in range better, I suppose, during that experiment, which of course was me. But nothing to do with the Twiist per se. It was really just kind of user error on Steve's part that he didn't beat me. So, but what about the Twiist? What do you think?
Well, the Twiist uses an algorithm the same as Loop. In fact, it is Loop that a company commercialized and put into a device that's approved by the FDA. And it's a small device the size of a
Oreo, double stuffed Oreo.
Double stuffed Oreo.
I said it like 6 times during this.
It's 2 ounces. It holds 300 units, which I like. And it does have tubing, which I'm not a big tubing fan, but I tried it. I used it for 3 weeks, and it worked extremely well. And I think it just gives another option. In fact, I took my double-sided silicone tape that I use for my Eversense, my Eversense, which is the implantable CGM, and I could put it almost any place on my body. Because it was so light, it just stuck to it. And I think the company will come out with shorter tubing for people that want to wear it kind of like a patch pump. And I'm also waiting to try it when it integrates with the Eversense 365. So I have that in, and I'm waiting, and I heard it's going to be in February. Okay. So it just, like you said in the beginning, you pick the CGM and you pick the pump, and eventually we'll be able to pick both and marry them together.
Yeah, and I think that's, it's not a specific question here, but that's maybe the number one thing I get asked. What pump should I be on? What, like CGM should I be on? And there really is, it's not a cop-out, but there's no kind of right answer. Tubing or not, you want to interact mostly with your phone or on the pump, or, like how aggressive the algorithm is or what CGM it works with, and all of that. So really kind of educating yourself. We've done a ton of content on this. Probably our most famous is where we did the speed dating, when I went on little dates with all these different systems. So, really kind of like looking into these, asking your endo, and most of them have like a 30-day trial period or something like that. So if you're not Steve Edelman and you get to try these things, you can through kind of your endocrinologist.
Well, for Jeremy, I get them for him.
Yeah, then I get the, used ones from Steve.
Well, let me just say that, we talk about this in our conferences at UCSD and the VA, and every system is different. And one thing I can just say is this, certain systems get a bad rap. They say it's not very, aggressive, and this one's better, that one's better. But I think it really comes down to the settings in your system, and a lot of settings aren't set to the maximum level where you can get the best control. And a big part of it is the user. Any person with diabetes that's not paying attention is going to have terrible blood sugars. I don't care what system they're on. So it's a combination of getting a good system, and I think they're all good. It's putting your own effort into it and learning how to use it, and making sure your settings are correct. And I've seen settings really set the wrong way in patients, and I can tell you all about one I saw on Tuesday, but we don't have enough time.
All right. So this person has been diagnosed for almost 8 years. Is there truly a solid plan to stabilize your blood sugars versus always counting carbs and being in the exhausting cycle? Well, if we knew the answer to that, we wouldn't be here doing kind of everything that we're doing. So first of all, this unfortunately is part of type 1 diabetes, that it's, the roller coaster, the ups and downs. If you eat the same thing today as you did tomorrow and you bolus the same amount, you might get kind of different results. So it's kind of a comprehensive discussion, but really getting on the technology, getting on a pump and a CGM, getting a provider. It doesn't have to be an endocrinologist, it could be an NP or a general practitioner that knows what they're doing with these adjustment settings. Think about your diet, the carbs. The number one thing that I think I'm always telling people in clinic after we get them on the system, we get their things dialed in, is still pre-bolusing, that you got to bolus before you eat. And that simple of just 20, 30 minutes before you eat, I put in 30 grams of carbs for basically every meal. And then I put in the additional when I start eating. That little kind of trick can really help people get like off that roller coaster. But Steve and I mean, if you watch this burrito challenge, you'll see that I went from basically 70 to 180 and I stayed in range, but just barely. So, a lot of times.
How'd you win?
Yeah. I ended up slightly lower than you. So I won. People kind of love when we don't do great. And I didn't do great, but that was with planning for this meal for like weeks and, investigating what I was going to eat and thinking about it. And even with all that and being on one of these systems, still it was definitely a roller coaster. So I was in range. I wasn't happy about it. So it's a way to say empathy, sympathy for the condition, but then also with the right tools, like you can get it pretty dialed in.
Yeah, we actually cut the burrito in half, and I started off great, but then my gastroparesis kicked in. But I would say this to you who asked that question, and to all those listening: try not to be perfect, because if your time in range is 70%, that has been studied to be a level that you will avoid diabetic complications. You don't have to be 80, 90. Your A1C just needs to be around 7. I know many people look at their labs and they say, it says normal says less than 5.7. That's not for you. That's for people without diabetes. So don't beat yourself up. Do the best you can. Laugh about your diabetes and keep watching TCOYD.
That sounds like something I would say. Proud of you.
I learned from
you
the
learned
best.
From me, yeah. So can you wear your sensors during dental x-rays? Yeah, as far as I know, any x-ray. You might have an issue with MRIs is the one thing. But, I just got a dental x-ray actually yesterday. I didn't even think about it. So I hope my sensor's working, but I think it is.
Yeah. Every time you get drilled by the dentist, don't worry about it.
Okay. My test result for kidney function came back as stage 3 kidney disease. I was very surprised. Is there a way to reverse this?
Yeah, well, that's my area because I have stage 3 CKD, and it always hits you hard because, that's a real complication. I think the important messages to everybody is you should all get screened. And the screening test is the urine albumin to creatinine ratio. A lot of doctors don't order it. It's a simple urine test. But what can you do? And I'll answer this really quickly. We talk about the pillars. Well, glucose and blood pressure control is key. Then being on a medication that's old as dirt, ACE inhibitor like captopril or lisinopril. These protect the diabetic kidney, but not as much as the next pillar, which is an SGLT2 inhibitor. I take Afrezza. There's also Jardiance. These are actually proven to be extremely effective, and it reduced my urine albumin to creatinine ratio, which was like 400, now into the slightly abnormal range. To me, it saved my kidneys. And lastly, there's a new medication called Corindia. That's approved for type 2, and so is Afrezza. But a lot of doctors use it in type 1s, and insurance companies do not give you a hard time because they know how much it costs to take care of someone on dialysis. And I should say Ozempic, which of course we all know what Ozempic is, GLP-1 approved for type 2, and that has been shown to reduce the progression of chronic kidney disease. So if you think about all those things, there are things now that we never had before, and I would hope that you would never progress to needing dialysis or a transplantation. And we have information on our website as well.
Yeah, and I think Steve does struggle with this, and I order the labs for him every couple months or whatever, and he literally makes me look at them first to make sure that they're okay before I kind of talk to him about it. So like the point there is that this is a bothersome thing, and I think it's something you got to jump on. And if all those names of drugs didn't make any sense to you, the point there is there's a lot of medications that are available. And
I didn't hit it.
The only thing you got to do is take another shot, unless you have chronic kidney disease, and then maybe you shouldn't. But things like, avoiding smoking and like kind of lifestyle changes, these are all kind of the healthy things that we should be doing. And all those drugs that Steve just mentioned, like Ozempic, GLP-1s, and these SGLT2s, we're using more in type 1 diabetes kind of anyways. So don't think that you just got all this stuff just thrown at you just because you have CKD. But the bottom line is, it is at least, at a point that you can still stabilize it, and you can live a full kind of normal, long life with stage 3 kidney disease, which I know sounds ominous.
Let me just say one last thing.
Mm-hmm.
Please get yourself to a good kidney doctor, and it specializes in diabetes. That makes all the difference in the world. And I always say, go early. Don't wait until your numbers are way out of range. And if your doctor doesn't want to refer you, get another doctor, because this could save your life.
All right. true rapid fire line. Only one person can say something, so I'll go first. Keep insulin from spoiling. I would like to know if there's a device container I could keep in my car, workout bag to keep insulin from going bad. So I love this question because insulin is actually really, really stable. And this whole thing of like temperature is really overblown. People will pack like ice trays or whatever to go like traveling with and things like that.
Yep.
It's fine at room temperature, for probably honestly a year or more. So if you're not using it, keep it in the fridge. If you're just doing kind of like normal room temperature stuff, that's fine. If you really have it you don't want it in a hot car or like an extreme environment. But aside from that, you're totally fine.
Okay, I think the other person does a quick rebuttal.
No.
Just keep it in a dark place that doesn't get shaken around. Like just in the middle of your suitcase.
Okay.
That's it.
You lost
You're allowed to add something.
Now I get to go. No,
it's my turn.
You lost it. Should lipid tests be done with each A1C test, including ApoB, little a? So generally we say you need to get your lipids done like once a year, unless maybe you're starting a therapy or modulating it or something like that. Do we do these more kind of sophisticated subsets of particle size and things like that? Not really. We really still think we know that the LDL is probably the most important thing. In my view, if you have type 1 diabetes and you're over 40, you should absolutely be on some kind of cholesterol lowering medication, usually a statin, because we're moving away from these numbers to just treating the risk that people with type 1 diabetes have. So please don't put that off. All right, Steve, you have earned another question. Let's see here. Why do I have to move after eating, regardless of how much insulin I take? Well, maybe this is about
postprandial highs.
Yeah.
Well, what you're referring to sounds like, your blood sugars go up after eating. The only way to control it is to do exercise. And unfortunately, that may be the case. And I would say you might have to experiment how much insulin you're taking, but nothing wrong with going a brisk walk to bring your blood sugar down, getting on an exercise cycle. I know many people who work in an environment where they have a treadmill and exercise cycle nearby, but I would say you might think about using Afrezza too. That might help you get to the point where you feel like you have to exercise after every meal.
And, I'll throw this on top for you.
And by the way, we got plenty of time, so don't rush.
I know. Any suggestions to better absorb insulin? That's kind of the same type of thing. Anything else you would say there?
No, what do you think? Rub your arm, right?
I honestly think changing your infusion site. I was just saying that I think the reason that I went low is I let my infusion site go way too long, and I changed it, and I've got this like big pump bump now, and I think that's just like a depot of insulin there that's like slowly leaking out and made me go low, and that happens to me every once in a while. But otherwise, it's it is helpful to kind of move. And the thing that people don't know is that heat really, really increases insulin absorption. And this comes up that your blood sugar's gonna be fine, but you're out in the sun, you're in a hot tub, something like that. If you get hot, it can increase the absorption, which can be a good thing if you want your blood sugars to come down, but it can also just something to be aware of that if you might go low. All right, how would you answer this one, Steve? Which CGM is the most accurate?
Oh, okay. Well, every CGM has to present studies to the FDA, and they have a thing called MARD, mean absolute relative difference, and the lower the better, and they all say mine's 8, mine's 9, mine's 10. You know what? I think they're all in a pretty good range, and using them with insulin pumps on these automatic insulin delivery systems, I don't think we ever have serious issues of people going unusually high or low because the number is abnormal. Now, if the sensor is really off, of course that could happen. So I would say, like you would say, pick the sensor that has the form factor that fits best for you and your pump or your InPen or just your regular old MDI system.
Love it. All right. This is a good question. They're all good. What range would you recommend for a type 1 diabetes teenage athlete or anybody? Do you go for 70 to 140 or 70 to 180? So 70 to 180, we've called time and range forever. 70 to 140, people are now using this phrase time and tight range. And I actually did a debate with somebody on this, like in that a major diabetes conference.
And you destroyed them.
Destroyed them. So I was like 70 to 180. Oh, man, I hit it again. They were 70 to 140. And all the evidence is for 70 to 180, that's plenty good enough to, if you keep it at 70% or higher, to avoid long-term complications, keep people safe. 70 to 140, more alerts, more alarms. If you're pushing your blood sugars to be kind of in that really tight range, there's an increased risk for hypoglycemia. But, if you can do it, if you can stay with 70 to 140 and it's no sweat off your back or your kid's back, then great. But please, this isn't like we were talking about earlier, this desire to be perfect for perfect's sake. We are not going easy on people when we see an A1C of 7 or time in range of 70 to 180. That's where the evidence points to, and going more aggressive can often lead to worse outcomes with more hypos, pulling out your hair, going crazy because you're aiming for something that's not realistic a lot of the times.
What's the goal for elder athletes?
Elder athletes like you?
Yeah.
I don't know, like 200 to 250.
We should say that, if you're a type 1 and you get pregnant, of course, they want to keep your blood sugars tight. But I totally agree with Jeremy. I was totally against this time in tight range. We have an article on our newsletter, time in tight ass range. And that's basically what it is. So there you go. Maybe in the future, but not now.
Are you done adding on to my question? You just literally can't help yourself.
Well, this is supposed to be a back and forth.
All right.
You're welcome to comment on my answers.
Okay. Well, how do you prevent or manage exercise spikes? Another great question. So I guess this is mine. We did a whole thing with Aaron Kowalski, who's the CEO of formerly JDRF, now Breakthrough T1D, on exercise in general, because we always talk about this. It's probably the thing that we still struggle with the most. It's exercise is good for you. Like everybody knows that. And I'm not going to stop exercising, but it can be difficult. You can go low during, you can go high after. For the spikes, people generally mean this, that they go for a run, their blood sugars or exercise, whatever, and their blood sugars are fine. And when they stop, their blood sugars go through the roof. And what's happening there is that when you're running, I'm just using running as an example, your adrenaline gets going. You start mobilizing blood sugar for your body to use. And then when you stop, you still have all that adrenaline that's going. And now all of a sudden your muscles aren't using that blood sugar or that glucose. So it goes into the bloodstream and it kind of spikes. So prolonged cool downs, you go for your run, but maybe 20 minutes afterwards, you walk the last couple blocks. If you're on a exercise bike, you can do kind of like a slow, basically ease yourself back into your normal living. And then also you want to make sure you're not too aggressive with turning off your pump or removing it, things like that, because the worst situation is you take off your pump and then everything I just described is still happening, but you have no insulin on board. So sometimes people will even take a little bit of a bolus when they're done. All kinds of tips and tricks to play around with it, and eventually, if you do kind of similar, consistent exercises, that you'll figure out something that works most of the time. Thank you, Steve. All right, I know that was tough for you. Let's see. How to manage foot on the floor blood sugar rise in the morning. First of all, maybe say what that is when using Control IQ, but anything. Currently, I do a small bolus, but there's something else. So what is foot on the floor, and how do you deal with that?
Yeah, foot on the floor syndrome is common for people with diabetes. It's like you're doing great while you're lying in bed, but when the instant you get up and stand up and brush your teeth and do what you're doing, your blood sugar goes up for no frickin' reason. And a lot of people will say to Jeremy and I, you know what? I went in for my fasting labs. I woke up at 110, but my blood sugar when I measurement at the lab 2 hours later was 240 despite not eating anything. So when you get up in the morning, there's all these anti-insulin hormones that come out. Epinephrine, norepinephrine, glucagon, cortisol, and these things will raise your blood sugar. If you had laid in bed and slept 3 more hours, you'd be perfectly fine. So it's sort of like maybe the exercise story too. Some people need to take a small bolus the minute they get up. For me, 2 or 3 units, even though I haven't had anything yet, because you are resistant to insulin in the morning. Jeremy will tell you, if he was allowed to speak, that's why it's the best time to exercise in the morning, because you're resistant to getting low. So a lot of people have it. You just got to be ready for it. Maybe give yourself a little bolus and then sleep in for another 20 minutes even would be helpful.
That's good advice. I love it. Sleeping in sounds amazing. This is one for you, Steve. Is there a connection between frozen shoulder and type 1 diabetes?
Man, you have a complication, just come to me. Frozen shoulder is one of the rheumatologic manifestations of diabetes. It's super common in type 1s where you have what they call adhesive capsulitis. You get your adhesions in your shoulder. It hurts like hell. You can't put your hand behind your back. You can't even function. If you don't do anything, it usually goes away in like 2 years, a long time to suffer. But if you go to a physical therapist, and even an orthopedic surgeon sometimes can do some more maneuvers to break up the adhesions. And that's also associated with trigger fingers. And ask Jeremy, I just got my finger injected for my 4th trigger finger. So we did a great video and podcast on it that goes into this in a lot more detail. But yeah, unfortunately, it is something that's common. And I would say, in my experience, more people get it who have had type 1 a long time. I don't really see people who have had it 5 or 10 years come down with it. So something good is happening. Maybe control is better now than it was 20, 30 years ago.
And this is something we always talk about, that like literally we'll get an email, from these medical societies, like new study linking type 1 diabetes to, hair loss. Like there's always something. And we say, just add it to the list. So it is unfortunate, like some of these like rheum conditions, clearly celiac disease, thyroid conditions, other autoimmune. The good news is that we always talk about people with type 1 living longer, even than people without diabetes, because of all this additional work that we're doing. What is that?
Wrinkles.
Oh, well, we'll talk about that.
Okay.
But yeah, because you're seeing your doctor maybe than you would otherwise. You're, more on top of your diet or exercise than maybe you would have been if you didn't have diabetes. And those things pay off. So it's a bunch of stuff we have to deal with. But in the end, there are some positives. And the other main positive is?
People with diabetes have less wrinkles than those without. That's a bona fide study. Jeremy looked it up, and there is data to suggest that is the case. So that's why I look 42 years old.
He's never seen a drop of Botox in his face. This is all just diabetes saving his face. So some good news there. Curious how the menstrual cycle impacts numbers, how to approach it, how to stay calm, and provide care for my daughter. So this is something. Honestly, I have a lot of empathy for women with type 1 diabetes for 2 reasons. Having to deal with menstrual cycles and then pregnancy is just something that we just don't have to deal with, and those can be really tough. So menstrual cycles, like everything else, is very variable. Some women with type 1 diabetes or type 2 diabetes have no issues. Their insulin sensitivity doesn't change at all. They don't even really notice. They don't have to kind of talk about it at all. On the other end of the spectrum is people that notice typically, when they're about to go through their menstrual cycle, that they become more insulin resistant, need more insulin around that time. They might have a different profile set up in their pump, which can kind of help with this. But I would say more often than that, or not, 80-90% of my patients don't change their kind of insulin settings around their menstrual cycle. They might just give an occasional more bolus or whatever it might need to be. But if you're worried about this kind of scaring your daughter, it really is not like a major change for most people that I think should be kind of fear-inducing.
Yeah, I'll just say that there was some data that just came out recently that women did much better with hybrid closed-loop systems, because if you know they give insulin when you need it, it turns it off when you don't, and it does help go through the ups and downs of menstruation. And I would say I agree with Jeremy. All my patients, they all have different issues, so there's just no one set answer to deal with menstruation.
Yeah. So this is a specific question. I'm a newly diagnosed 28-year-old male. This is actually a diabetes educator. Endo just ordered screening autoantibodies. Results came back positive for only one of them. C-peptide is normal. Is this consistent with type 1 diabetes? So it's tough to say. So we measure 4 antibodies now, and when 2 or more of them come back positive, we say that this is what we'd call, stage 1 or stage 2 type 1 diabetes. So with only one of them coming back positive and blood sugar is completely normal, no. But I would want to repeat them again probably in 6 months, see where they're at. If it's still the same, then you can think about another 6 months or maybe even annually at that point. With this one antibody positive, that's probably one of the bigger gray areas.
Yep. Sometimes
they can go away. Sometimes it can progress, but there's not a universal thing that we can say when people have that.
Perfect answer.
Thank you. All right. So this is interesting. What are your thoughts on when to take electrolytes?
Electrolytes like Gatorade kind of
Yeah,
thing?
or like, sodium, potassium,
Yeah.
something like that.
Well, I would say this, that if you're a athlete and you sweat a lot, and sometimes those electrolytes will help you from getting dehydrated, which could contribute to producing ketones and ketoacidosis. That's kind of an extreme example. I would say most people don't need electrolytes, but if you get cramps at night in your calves and your legs, then it might be a good thing. And I think it's important to know that things like Gatorade, and there's other competitor products, we don't have any affiliation with any, but if you work for Gatorade, give me a buzz. We need another sponsor. I think it could be okay. The only thing is, if you have chronic kidney disease, you got to watch your potassium level, and some of these electrolytes have high potassium in it, and that's just something to be aware of. Gatorade has very little, and that's not a concern, but some of these other high concentrated electrolytes.
Yeah, totally agree. I love this one. Thank you for your honesty here. Stinky pee. Is this common for type 1 diabetes? I think it might be the Lipitor, but I'm not sure. So that's actually one thing I've not heard of in type 1 diabetes. I'm just thinking of how we would design this study. We just have a bunch of people pee, and we have like a stinkiness index to see like if that's associated with it. No, so that doesn't come up. Sometimes people will say if they get protein in their urine, that their urine can become like a little bit more foamy, but nothing to do with like the color, smell, anything like that.
Yeah, if you eat asparagus, your pee's going to stink. But the other thing too is if you have a low-lying urinary tract infection, your pee could smell. So that's the only thing I can add to that. And there's no, I think your pee smells good, Jeremy.
Thanks, bud. I don't overeat, but I'm prone to hypoglycemia and often eat when I don't want to, so I'm overweight. Would a GLP-1 help or be dangerous? So, yeah, a lot there. So,
Yeah.
I guess we haven't talked about this at all yet. That
It's a good topic.
I had clinic the other day, and literally every single one of my patients, they're all type 1s, were on GLP-1s because I'm their doctor. And just a way of saying that we're using it more and more. It has the same effects of helping people lose weight, helps your blood sugars a little bit. You can use less insulin. It hasn't been officially tested, but I think will be shown to reduce heart disease and kidney disease, just like it does in our type 2 patients. So there's a lot of reasons to use it. You just have to have a prescriber that's on board with it, knows kind of how to do this. And then the insurance is the major bugaboo. I've actually just been straight up diagnosing or putting that people have type 2 diabetes or sometimes a combination type 1, type 2 in the chart. Because what is type 2? It's insulin resistance, it's these weight issues, it's high blood sugars, a lot of things that we're kind of dealing with here. So we're using them more and more, and they're really, really effective.
Yeah, and they've also been shown to help people with obstructive sleep apnea, chronic kidney disease, and reduce heart disease, especially congestive heart failure. And I agree with Jeremy. There's no reason to believe they would not be just as effective in type 1s. And there are several studies going on now for the approval of these drugs in type 1. And, I know that the oral Ozempic and oral Lilly drug, it's going to have a different name when it gets approved, will be available, and it's going to be available for only $150 a month.
Yeah.
So that's something that you'll have to talk to your doctor about and use the tricks of the trade to get it approved.
Yeah, and just to answer your specific question, all the data shows that there's no increased risk of hypoglycemia. However, you're going to need to probably use less insulin, so you're going to need to back off that while you titrate up the GLP-1. And if you don't do that, then you might have more lows. So that's what we're just talking about, that this isn't just a drug you start and you're off to the races. How to titrate it, side effects. Like there's a lot of counseling that goes into it. Okay, so we're kind of getting to the end of it. Are there big categories or topics that you feel like you're missing? People always, second most common question I get other than the pump is like, well, like what's going on in the type 1 world? What are you excited about? Like, are there things, how do you answer that?
Well, I would say we did a pretty good job. What about gene therapy? Can you give us what the update on that is?
We did, there was a question about that. So we did, I think, a really good podcast right here on gene therapy in type 1 diabetes, basically using a completely safe, innocuous virus that you can put an insulin gene in, and really whatever gene you want, And in this case, injected into people with type 1 diabetes, the virus gets into the muscle tissue, releases the gene. So all of a sudden, guess what? You got muscle tissue that's able to make insulin, which is pretty amazing. And that you could do this potentially without, immunotherapy, because you're not putting in new cells or new kind of it's not like a transplant.
Just new viruses.
It's just new viruses. The virus goes away. It's just a delivery mechanism. And, that is now moving forward to clinical trials. They haven't started clinical trials yet. But I think it's great because when we talk about things like gene therapy or these things that we've heard about forever, it's usually like maybe in 15 years. Like they've cured dogs, they've cured mice, they've cured monkeys with this approach, and now getting into actually starting clinical trials. That still usually means that that's probably another 5-6 years at the shortest until it's actually available clinically. But hey, a whole new area to talk about in addition to islet cell transplant and these TZOIDs and things like that. So pretty cool to have a whole nother avenue that we're exploring in diabetes.
Yeah, you listen to the podcast. It's complicated technology for the layperson, including myself, because I know nothing about gene therapy at that time. The company's called Kriya, and they've used gene therapy, they and other companies, to cure 8 serious conditions. Mm-hmm. And the folks at Kriya, they have many different targets they're using, different diseases, but type 1 diabetes is top of their list. Mm-hmm. And theoretically, it could be good for any person with diabetes that needs insulin. And it does have that glucose kinase part of it, sorry to get technical, that helps regulate how much insulin is, I guess, produced and put into the bloodstream. So there is some regulation to it as well. It's pretty amazing. I'm waiting to get my shot into my bicep, but my bicep's so big, they're going to go to my thigh.
Well, with that, I would say if you're playing the drinking game, I'm sorry you weren't looking forward to getting super drunk at 11 a.m. Pacific Standard Time, but that's Steve's fault. And I actually added a couple too. I can just throw in a couple extra shots for you guys. Thanks for listening. Honestly, we've got a ton more questions. This, might be some of the more questions that I've seen. So we will absolutely answer these online. I don't know where exactly.
On our blog.
On our blog. Okay. So don't feel left out. Or if there's other questions that come up, please add them. But hopefully we highlighted some the big areas. There's just so much to talk about in type 1 diabetes, which is a good thing.
Yep.
And everything we talked about, there's new advances in it, even these complications, kidney disease, et cetera. So a great time for type 1, a lot to talk about. If you do want to hear more, there's a whole lot of stuff on our website. You can click on the podcast, or you can go to watch, and then we have a video vault where everything's organized by category. I want more on exercise. I want more on diet. I want more on whatever. We've done a video on it or a podcast, trust me. And if you want to meet us to see us in person, definitely come to San Diego, August 14th, 16th. The one conference that is online, available to register now. Just go to TCOYD.org, click the events tab, and then you'll see it there.
Yeah, and if you came to this live, email me and we'll get you a discount on your registration. I just made that up. Hopefully I don't get yelled at, but steve@tcoyd.org. And it's an amazing event. And this whole recording will be online as well if you want to forward it to friends that missed it or you want to hear something again.
Yeah. Well, with that, thanks for watching. Make sure to tell your friends, like, subscribe, follow, all those kinds of things. We do count on these views to keep this going so we can deliver this content for free. Always fun, Steve,
yeah.
To do this with you. The time really flew. So thanks, everybody, and we'll see you on the next one.